in Maximal Care Hospital. He holds the European Diploma in Neuroradiology. He is having extensive expertise across the spectrum of neuroradiology, neuro-oncology, and spine imaging. He is a part of stroke team in BMC, and he is establishing the stroke program and licensing here in BMC. And for moderating this session, we have Dr. Isam, well-known neurosurgeon. He doesn't require any introduction. He is with us here in Burjeel Medical City, and he is leading the head of the department of the neurosurgery department here in Burjeel Medical City. Myself and Dr. Yasir will be coordinating this session of intraspinal tumors. Over to you, Dr. Adel.
Thank you, Dr. Amol. Good evening, everyone. Thank you for joining. I'm gonna talk today about the intraspinal tumor. It's a large subject, but I'm gonna try to make it as simply as possible. And I'm gonna talk about the most common tumor. I'm gonna share my image, my screen. So in order to be there is always a large differential diagnosis about the intraspinal tumor. So in order to minimize this differential diagnosis, we need to look at the location of the tumors. So first of all, we're gonna speak a little bit about anatomy. Then after the anatomy, about the tumor location, the most common tumor and the typical imaging features of each one of them, some rare tumors and some tumor mimickers. We're gonna start with the anatomy. In this image, we see the.
Sorry to interrupt you, Dr. Adel. If you can just take your mic a little bit closer.
Okay.
Few participants, they are mentioning it, voice is low.
Okay, yeah. Is it better
Thank you.
now?
Thank you.
Is it better like this?
Yeah, or you can just increase the system volume, no? Your system volume, if you can just increase a little bit.
Okay. Okay, now is it better now?
Yeah, relatively better. Yeah, if you can, yeah, just it's okay. Relatively better. Yeah.
Okay. So in this image, we see the anatomy of the dura. We see here the dura mater, and directly adjacent to it, we see the arachnoid, which is the very thin membrane attached to the dura from the inner surface. And these are the trabeculae of the subarachnoidal space. These are things we can't really see in the brain and in the MRI. We can see the dura mater, and here we see the exiting nerves on both sides. And the pia mater is very thin membrane which attached to the spinal cord. And here is axial view of the anatomy of the spinal canal and spinal cord. We see the bone is the vertebral body surrounding these inner structures. So from the inside we have the dura mater, and adjacent to it we see this arachnoidal mater, and between the bone and the dura mater, we have this space. This is the epidural space, which there is a tumor which can originate in this space, and other tumors originate in the subdural space. And we have here the spinal cord. So about the compartment of the spinal canal. As we said, we have the extradural space, which contains fat tissue, vascular, venous plexus, and the vertebral body is outside this region. And in the intradural space, we have arachnoidal trabeculae, CSF, vessels, and of course the spinal cord inside. Here's more simplified image about the thing we really see in the MRI. We see the dura mater, like this thin hypointense line, and the subarachnoidal space is the subdural space itself, because this is the subarachnoidal space, and inside it we have the spinal cord. This is the epidural space around it. So about the location of the tumor, so we have the extradural and intradural space. As we have in the intradural space, we have the Okay, just one moment. I need to change the microphone. Just one moment, please. You can't hear me?
We can hear you. We can hear you, but voice is little bit low comparatively.
Okay, then I just
Yeah. This is ideal. Now it is clear.
Is it clear now? Okay.
Yeah.
Sorry. Okay. The tumor location, we have two main locations, either extradural or intradural. As we have in the intradural space, we can think about only two components, which is CSF and the spinal cord, just to make it simpler. If the lesion originates within the CSF, then it is extramedullary lesion. But if the lesion is within the spinal cord itself, it is intramedullary. Here I have some images about the extradural tumor, which is outside the dura. And another one is located intradural, but if you look, it is within the CSF itself. It's compressing the spinal cord, but it has nothing to do with the spinal cord itself. It is intradural extramedullary lesion. And this one, it is intradural, but if you look, it is within the spinal cord itself. Here are the three tumors in one image: extradural, intradural, and intramedullary. Now, the most common tumor according to each location. About the intradural tumor, as I said, we have two locations. So each time we have to say intradural, extramedullary, intramedullary. It's a little bit confusing. So we can change this to almost intradural. If we speak about intradural, it is clearly not involving the spinal cord. And if we say intramedullary, it's obviously intradural, but it is within the spinal cord itself, just to make it a little bit simpler to understand it more. So these are the three most common locations. So our first things to do is to know where the lesion is. Is it extradural or is it intradural? Because each compartment has its own common tumor. We're going to start with the extradural tumor. The most common tumor are bone lesions, which are originating in the bone, and then they extend intraspinal. The second one is the nerve sheath tumor. In the intradural space, remember, it is in the CSF itself. It has nothing to do with the spinal cord. It might compress the spinal cord, but it's not originating within the spinal cord. There is three most common tumor: meningioma, nerve sheath tumor, and metastasis. About the intramedullary, there is also the most common tumor: ependymoma, astrocytoma, and hemangioblastoma. There is, of course, a lot of rare tumors in each compartment. We're not gonna speak about them, just a little bit, just some images. We're gonna concentrate about this upper row of these tumors. So the first location is the extradural location, extradural tumor. The most common tumor are the bone tumor. And the most common bone tumor is the bone metastasis, because bone metastasis has commonly soft tissue component which will extend into the spinal canal in the epidural space and cause spinal cord compression. So the most common tumor in the extradural space is bone lesion, mostly metastasis with intraspinal extension. There is also another bone lesions which less common, like multiple myeloma, chordoma, lymphoma. It's usually difficult to say from the images itself which kind of tumor. Of course, if there is multiple lesions, most likely metastasis. Then if it's solitary lesion, we have to look in the other imaging features. And the nerve sheath tumor, we have also the schwannoma and neurofibroma. We're gonna see some images. This is the schema about the bone metastasis, which originate in the bone itself. Then it will go inside the spinal canal, compressing the spinal cord and the dura sac, compressing here, for example, this myelopathy signal. This is, for example, a patient who has a primary tumor with spinal vertebral body metastasis involving this vertebral body in the spinal thoracic spine. There is pathologic fracture involving the superior, inferior endoplates, and there is also retropulsion of the posterior vertebral body margin, and it's not causing any spinal cord compression because there is CSF space. If you look at this image, we see like a lesion which is in the epidural space. This is because of the extension of the soft tissue component intraspinal. There is also might be here involvement of the left neuroforamina. Another patient who has marked spinal soft tissue component of a bony metastasis, which involving almost surrounding the spinal canal. We can see the dura. The dura, it's this thin hypointense line. It looks intact, and this soft tissue is causing encasement of the spinal canal. Here there is this classification. It is used usually by radiologists to talk about the degree of the spinal cord compression or narrowing of the spinal canal. It's called epidural spinal cord compression scale. There is multiple grading according to the abutment of the epidural fat of the CSF, for example, here. And then if the spinal cord, there is indentation of the spinal cord, if there is rest CSF or not. And the most grade 3, if there is severe stenosis with spinal cord compression, and likely always a spinal cord edema, myelopathy. So the first most common tumor in the epidural space is the bone metastasis with secondary intraspinal extension. And the second most common tumor is the nerve sheath tumor. It is very difficult to differentiate in imaging these both tumors from each other. But usually the schwannoma is more common than neurofibroma. Here we're gonna have some images. This is a lesion in the left neuroforamina. It's epidural. Here again we can see the hypointense signal of the dura mater, which looks normal, but there is this soft tissue lesion which is T2 hyperintense. It's causing remodeling and enlargement of the neuroforamina. When compare this normal side on the right with the left side, there is here marked enlargement, remodeling of the spina of the neuroforamina. The lesion, the schwannoma, mostly is very bright in T2. It has this T2 hyperintense signal, and which show always contrast enhancement. Could be homogeneous or inhomogeneous, but usually there is always enhancement. Here's another patient who has also epidural mass lesion within the neuroforamina. It causing this remodeling of the neuroforamina. We see that the cortex is still present and intact. This feature to differentiate slow growing mass lesion versus osteolytic lesion, which will cause destruction of the bone. Here we have only remodeling, and because of the slow growing mass lesion. This is also schwannoma. About the neurofibroma, they have the same imaging features, but if we have multiple lesions like this neurofibroma, this patient has a neurofibromatosis type 1, which has and has this plexiform neurofibromatosis. So the neurofibroma is usually multiple, while the schwannoma is usually one single lesion. Now, the second location is the intradural space. Here the lesion will be between the spinal cord and the dura itself. It's intradural. It could compress the spinal cord, but it's not originating from the spinal cord itself. For this tumor, we have to think and remember the M&Ms, because this chocolate will remind us about the 3 most common tumors, which are M and M. M for meningioma, N for Nephri tumor, and the second M is for metastasis. This is the way to remember this differential. We're going to start with the meningioma and Nephri tumor because both tumor are responsible for almost 90% of the intradural tumor. Metastases are also one of the differential, but they are less common compared to the meningioma and Nephri tumor. And especially the Nephri tumor is more common than meningioma, and especially the schwannoma. So the Nephri tumor, as I said, they are the most common intradural mass lesions. They can be anywhere, intraspinal, epidural, intradural, even intramedullary can be seen. The schwannoma is more common than neurofibroma. Both are difficult to differentiate from each other. There is the T2 target sign. It's non-specific sign. It is more associated with neurofibroma, but it doesn't mean 100% that we are dealing with neurofibroma if we see it. The thing is how to differentiate schwannoma from neurofibroma. Usually schwannoma is one lesion, is T2 bright, it has cystic degeneration. And sometimes it's associated with neurofibromatosis type 2. And the neurofibroma is usually multiple. But as I said, this is very difficult to differentiate. Here we have this lesion, it's not well seen in the T1. And the T2, we see like a lesion which is T2 hyperintense, compressing the spinal cord. If you look at the axial T2 to look where the lesion is, here we have the dura, which looks normal. The epidural space is normal. That's mean the lesion doesn't originate from the epidural space, extradural space. It is within the dura itself. And if you look here, we can see the spinal cord, which is compressed to the left. And after contrast, the lesion demonstrates homogeneous enhancement, compressing the spinal cord. So we have intradural lesion with T2 hyperintense signal and homogeneous enhancement. Most likely the diagnosis will be schwannoma. This is another schwannoma, but with some cystic degeneration, which is common in the schwannoma. Here also we see this lesion, which is T2 bright signal. One of the imaging features of the schwannoma, it's high signal in the T2. After contrast, we see some inhomogeneous enhancement. There is focal area of non-enhancement because of the cystic degeneration. And after contrast, we see it itself like there is some area of non-enhancing component. This is schwannoma with cystic degeneration. This is another lesion which looks exactly like this one. We have T2 hyperintense signal with some central degeneration, cystic degeneration without complete enhancement. The lesion itself, it looks very high in the T2, compressing the spinal cord, but this one was in the histology neurofibroma. It's very difficult to differentiate the two, so it's enough if we write in the differential Nephri tumor, probably schwannoma. It's nothing wrong in reporting this. The T2 target sign, this is a sign which sometimes seen in the neurofibroma, but it's not specific at all. This is the lesion with central hypointensity and surrounding hyperintensity. Its target sign, commonly seen with the neurofibroma, but non-specific. We saw that we have in the epidural space the bone tumor and Nephri tumor, and in the intradural space we have the meningioma and Nephri tumor too. So Nephri tumor can be seen everywhere. This is the first case we saw in the extradural space, and this is one in the intradural space, which is the most common location for this lesion. But Nephri tumor can be seen anywhere, like intra and extradural at the same time. This patient has this lesion, which it's not clear. Is it intradural? It looks within the spinal canal, but there is also component in the left neuraforamina and extraspinal. So to understand it exactly, this kind of nerve sheath tumor originate along the nerve root itself. It has component within the spinal canal, within the dura itself, intraspinal, and extend along the nerve sheath extraspinal. And it has this dumbbell bell sign. It's narrowed in the middle with both components which are thickened in the intra and extradural space. It's called dumbbell sign. That means we have a lesion which is intra and extradural. It is within the nerve sheath tumor itself. Then we go back to the M&Ms about the intradural tumor. We have the meningioma and nerve sheath tumor, which are the most common lesions. We're gonna speak now about the meningioma, the second most common tumor after the nerve sheath tumor. This tumor is commonly seen by female patients more than male. Its most common location is the spinal cord itself, the thoracic spine. It's somehow commonly at the anterior surface of the spinal cord. How to differentiate meningioma from the most common tumor, the schwannoma? Usually the meningioma is iso-intense, while the meningioma is iso-intense in the T2, while the schwannoma is very bright in the T2. The schwannoma will show cystic degeneration, but the meningioma is very rarely to demonstrate any cystic degeneration in the spine. It is well marginated, homogeneous enhancement, and Duratail sign. And there is also one sign called Ginkolev sign. I can share it with you. So this is a patient who has in the thoracic spine a lesion. It looks here is the T2. It's not very well appreciated in the T2, but it is intradural. It has T2 iso-intense signal. It's not T2 bright as schwannoma. It's T2 almost similar to the spinal cord itself. And after contrast, it shows homogeneous enhancement. There is no cystic degeneration within this lesion. There is minimal Duratail sign can be seen. And of course, there is spinal cord compression here. And the lesion itself here, it's demonstrated here in the axial view homogeneous enhancement, and the spinal cord is this thin area which is compressed completely. Another patient with the same morphology, T2 iso-intense signal, well marginated lesion, intradural space, compressing the spinal cord. We can see it here. This is the lesion itself. It's not very bright in the T2, compressing the spinal cord with homogeneous enhancement, and this lesion is also meningioma. The spinal cord, there's some anatomy. We know that the spinal cord is within the dura. Here we have the dura and we have the spinal cord, which is surrounding by CSF. But how is the spinal cord itself, if it's surrounding by CSF, how is fixed within the spinal, within the dura? Why it's not moving? Why it's so fixed and stable? The spinal cord is stabilized through the nerve, the exiting nerve on both sides, but also there is one ligament, very thin ligaments which stabilize the spinal cords. It's called the denticulate ligament. It's bilaterally. We can see it here in this image to denticulate ligament, and in the coronal view we have it here like this triangular thin ligament, which is usually very difficult to be seen in the standard MRI, but there is somehow association with the meningioma, because when the meningioma originate intradural, it will originate from the dura itself, and it will surround this denticulate ligament, and it will push the spinal cord itself away to the contralateral side, but the spinal cord itself will be still attached through this ligament to the dura itself. And this is the ginkgo leaf. This plant has this name, ginkgo leaf, and how we see it now in the, if we have meningioma, Here we have this patient had this enhancing lesion. This is the tumor, this is the meningioma, and here we see the spinal cord itself. It is compressed to the contralateral side, but it is still attached through this very peak. This peak is the attachment location of the spinal cord with the dura. And as I said, the meningioma wouldn't invade this ligament. It will compress it, and we see that the spinal cord is trying to go to its normal position, and that's why we can see this sign. Now, the third most common tumor in the intradural space is the metastasis. Less common than the meningioma and nerve sheath tumor, but we can see them in the intradural space. Usually there are leptomeningeal metastases along the spinal cord itself, at the surface of the spinal cord, but sometimes they will invade the spinal cord, but they originate from the pia mater or from the nerve sheath around the spinal cord. If we are dealing with a patient with a child, most likely this leptomeningeal or this intradural metastasis are drop metastasis from intracranial tumor, most likely medulloblastoma. But if we are dealing with the adult, most likely is secondary to non-CSN malignancy, or it could be also drop metastasis from brain tumor like glioblastoma. Metastases are like everywhere in the body. There are multiple, more than solitary tumor. There are nodular, or it could be like linear enhancement along the spinal cord itself, shows sugar coating. We have here some images. We see this multiple nodular lesions which are intradural, aligning the dura. Here we have some epidural fat, and this lesion are along the nerves, showing enhancement, and they are here clearly leptomeningeal metastases along the spinal cord. And sometimes the leptomeningeal metastases are not nodular, they are linear, thickened layer of enhancement along the spinal cord and the cauda equina, which demonstrate like this sugar coating along the spinal cord. Now, the third location about this intraspinal tumor is the intramedullary location. Intramedullary tumor, we have three most common tumor and some rare tumor. We're gonna speak about the most common tumor, and the most common one is the ependymoma. The ependymoma originate, as the name said, from the ependyma. The ependyma is this layer of cells which is surrounding the central canal, the ependyma. That's why this tumor originates from the ependymal cells, and that's why this tumor is usually very centrally within the spinal cord itself. It is the most common intramedullary mass lesion, usually in the cervical spine. It will cause, as it originate centrally, it will cause syrinx, it will cause some cystic degeneration adjacent to the tumor itself, and they will it cause sometimes also bleeding adjacent to it, edema, and enhancement. This is the typical imaging feature of ependymoma, usually in the cervical spine, most common in the cervical spine. We have this lesion, which is clearly within the spinal cord itself. It's very slightly hyper-intense compared to the spinal cord. It demonstrates homogeneous enhancement, and if you look at the axial view, it is very centrally within the spinal cord itself, because it is originated from the spinal canal, from the central canal. Adjacent to it, we have some cystic component. Sometimes it's syrinx, sometimes it is just cystic degeneration adjacent to the tumor itself. And here we have some T2 hypointensity. This is hemorrhage, hemosiderin. It's called capsines. It's also very specific for ependymoma. And here we have another patient who has also intramedullary lesion, which is ependymoma, and there is cystic component adjacent to it, which is surrounding by enhancement. This enhancement is tumor. That means this lesion, this cystic component is the component from the tumor itself, and it should be also resected. While this another patient, it has also cystic component, but there is no evidence of any enhancement around it. So it might be non-tumoral cyst. It's just because of the compression of the lesion itself. Now, the second tumor intramedullary is the astrocytoma. It's the second most common tumor, usually by children, because we know that astrocytoma is commonly by children or by young adult. It's common in the thoracic spine, but of course it could be also within the cervical spine itself. It has ill-defined margin compared to the ependymoma. The ependymoma is well marginated, while the astrocytoma is ill-defined. It will cause the swelling of the spinal cord. It's extend along multiple segments of the spinal cord, and the enhancement is not always very obvious, like in ependymoma. And if we see some images, this is a child who has this intramedullary lesion which extend multisegmental. It's causing mild swelling and edematous enlargement of the spinal cord in the T2. In the T1, there is no difference. It's not well appreciated according to the signal itself, but there is very large mass lesion here. And after contrast, this lesion doesn't demonstrate very obvious enhancement. There is only patchy-like enhancement, and this was astrocytoma. Another patient has the same lesion, which is intramedullary. It causing enlargement of the spinal cord, some edema above and below the lesion itself, and after contrast, there is surrounding enhancement and some cystic degeneration within. And according to the patient's age is a key role in the diagnosis of the astrocytoma. This was also a young adult, and the histology was astrocytoma. Another patient with the same morphology, ill-defined margin. It's not very clear like ependymoma. And there is very minimal enhancement. We can see it here, and patchy-like enhancement in the axial view of astrocytoma. Now, the third tumor is the hemangioblastoma. The hemangioblastoma is the third most common tumor, and we know that it's a benign tumor, but it's a hypervascularized tumor. It can cause CSF seeding. Sometimes the patient have also component within the brain itself, and there is association with von Hippel-Lindau disease, but there is also sporadic tumor without von Hippel-Lindau disease. The tumor is usually intramedullary, but it's located somehow in the periphery, and it's causing like exophytic tumor in comparison to the ependymoma. As we said, the ependymoma originates from the central canal. That's why it's central, while the hemangioblastoma is usually epicentric, adjacent to the pia mater, and sometimes there is exophytic tumor. And if you look at it, you will think that the tumor had nothing to do with the spinal cord itself. This is a patient who has this area of cystic lesion and some inhomogeneous lesion adjacent to it in this cervical spinal cord. There is edema also, and in the T1 there is hypointensity, and after contrast we see homogeneous enhancement. Now, if you look, this cystic lesion is not this one. This cystic lesion is the one above, which doesn't show any enhancement. And if we go back to this T2, we can think there is some hypointensity underneath to it. It is in the spinal cords why is this lesion is not ependymoma? Well, it's not ependymoma because this could be also cap sign, the hemosiderin we saw in the ependymoma. But if you look after contrast, this lesion of T2 hypointensity shows enhancement. That means this is not blood, this is fluvoid. And the hemangioblastoma is highly associated with fluvoid because of the hypervascularization. And if you look here, it's not clearly within the spinal cord. It's epicentric compared to the ependymoma. It has more like pyramid-line location. Another lesion, this is the hemangioblastoma, how it looks. You see, this is the spinal cord, and this lesion has exophytic extension outside the spinal cord itself, but it's originating from the spinal cord itself. It's difficult to diagnose it, but if you see this fluvoid signal and this edema along the spinal cord and this cystic component with the spinal cord, then you have to think about the hemangioblastoma. So the intramedullary lesions somehow all looks the same, all have the same morphology, all within the spinal cord itself. So I'll just have a quick review. The ependymoma is the most common one. It has well-marginated borders. It has this cap sign. It is centrally located within the spinal cord, while astrocytoma it has multisegmental extension, ill-defined border, and the enhancement is variable. It could be a very mild enhancement. The hemangioblastoma, it has fluvoid signal, which sometimes look like the hemosiderin seen in the ependymoma, but this will demonstrate enhancement. This is the way to differentiate ependymoma from hemangioblastoma. And also the most common is most common. And for the astrocytoma, if we have a child or young adult, we have to think about it with the other imaging features. And for the hemangioblastoma, most of the patient in the spinal cord will have a primary in the brain, hemangioblastoma in the brain, which secondary CSF seeding into the spinal cord. So just look if the history, the patient has any brain tumor, then you can minimize the differential. Now I'm going to speak briefly about some rare tumors, because there is a lot of tumors in the intradural space. We have the myxopapillary ependymoma, which is usually along the caudal thoracic spine and the region of the conus medullaris. It usually causes this sausage-like extension. It causing remodeling of the spinal, of the posterior surface of the vertebral bodies. It shows enhancement. And the paraganglioma. The paraganglioma, it has sometimes this cap sign also, this hemorrhagic component in the surrounding, in the margin of the lesion. So the way to differentiate this one from the ependymoma is very simple. This lesion is intradural. It's not intramedullary like the ependymoma. It is outside the spinal cord itself. Some other intramedullary rare tumor, we have the subependymoma. We know we have the ependymoma itself, which shows enhancement. There is very minimal amount of case reports about subependymoma. The subependymoma, it's originate within the spinal cord itself. It doesn't show any enhancement. It looks like this bamboo leaf signs, like this feather of these plants. Is very rare. I've seen only one case. And there is also the dermoid cyst and epidermoid cyst. The dermoid cyst, it will be high signal in the T1, and the epidermoid cyst, we have to think about it if we see any restricted diffusion. And also intramedullary metastases are also seen, but rare. Now I'm going to speak about some tumor mimickers, which are usually this patient, for example. This patient has this lesion. If you look, we can see here the spinal the dura, and the lesion it's located outside the dura. It is in the epidural space. It shows marginal enhancement in the periphery of the lesion, and in the spinal in the T2, this lesion is just migrated disc sequestration, as we see in these images. Usually the sequester is on the anterior surface, but it could be dorsally, which will be very difficult to be confident to say it is migrated sequester. But the key feature to diagnose it is, first, at the same level, usually there is disc herniation, and the signal of the lesion itself, it's inhomogeneous. And if you see post-contrast, the lesion will show contrast enhancement, but more important, the disc itself. You see here there is very thin enhancement along the disc itself, showing that we have some reaction here after a history of extrusion or protrusion, which is help us to say that we are dealing with sequestration. This patient, as you see, there is a child who has this lesion in the spinal cord itself of the cervical spine. I would think about astrocytoma, to be honest. But if you look in the brain of the patient, there is also another lesions in this supratentorial, also in the left cerebral peduncle, and this lesion was Adam. It's not astrocytoma, it's Adam. So, as a take-home message, location is the first things to do. Locate the lesion, and according to that, you can think about your most common differential. Just a brief, we know that in the extradural lesions, we have the bone tumor with secondary extension intraspinal, and the most common one is the metastasis. In the intradural space, we have to think about the MNM, and the most common are nerve sheath tumor and meningioma. And intramedullary, we have also the three most common lesions. Mostly the ependymoma is the most common one, and astrocytoma common by children, and hemangioblastoma. Just look if the patient has any brain MRI to be more oriented. Thank you very much.
Thank you very much, Dr. Adel. Thank you indeed. Yeah, it was actually very, very directed. Yeah. I know imaging plays a very important role in the detection, localization, and the assessment of these tumors. And as you said, it gives detailed information about the tumor size, the extent, the involvement of neural structures, and it helps us during the management of these patients. The list of differential diagnosis is too long, and I'm sure you don't want to confuse people and mention all differential diagnosis of these lesions, but the list is too long. If everyone knows about only these tumors that you mentioned, this will be great. The point which I always try to remind the physicians when they request a scan, especially in children, we scan the whole CNS in children. So if you see a spine tumor in children, you have to look at the brain as well. It might be the primary is there, or to rule out any other tumors in the brain. But thank you very much. Actually, you simplified it very, very well, Dr. Adel. Thank you.
Thank you, Dr. Adel, for this nice presentation and this valued information. Your case is so much impressive and interesting. Thank you, Dr. Assam, for your comment from clinical and neurosurgical aspect. Now chance for our colleague for any question to Dr. Adel or Dr. Assam.
Dr. Adil, I have one question for you.
Please.
Just wanted to know a role of diffusion method imaging for assessment of these tumors.
The diffusion imaging is usually helpful if we are dealing with a lesion which is suspected to be epidermoid. It's very helpful. Diffusion imaging is also helpful to diagnose spinal cord ischemia. But there is some study about if you are dealing with the cell-rich tumor, sometimes the diffusion, it's also helpful to see if there is a cell-rich component within the tumor itself.
Because in extradural region, we see metastasis is one of the commonest differential we are keeping.
Yes.
So can we consider doing diffusion weighted imaging in every spinal case where we are suspecting?
Yes, if you have a patient with oncology background of metastasis, we can do it, of course. We can add it to our protocol.
Yeah, I may ask the same question in a different way. Is there a rule for CT scan in these cases?
If we are dealing with metastasis, but the rest of the region are not well seen. If it's intradural or intramedullary, we can't see it. Only if there is bone metastasis, yes.
I mean, after the MRI, if you have an MRI done and show that's intraspinal tumor, is there a rule of CT scan? Shall we do it?
If the lesion is extradural, we can see, of course, in the CT. If we are dealing with enlargement of bone remodeling, we can see it better in the CT, of course. Only if it's extradural, but intradural, intramedullary, there is no benefits. Or if we have, for example, if we have like this patient which has some, if we need to differentiate bleeding from calcification or ossification, because we had this case, Dr. Isam, with which has this calcification. We thought it's bleeding, but it was calcification at the end. In such case,
Correct.
yes, of course.
Thank you.
Thank you.
Any other question? Yes.
I need some. I will give you, but just wait. This one done manually. And this one I did.
One more question, Dr. Adil. Is there any role of dynamic post-contrast imaging in such tumors? Because recently I got to know in one of the article where I have seen people are doing dynamic post-contrast as well.
Yes, if we have a lesion which is related to dural fistula, if you have like arteriovenous malformation, the dynamic sequence is important to see how the inflow and outflow, because if you are suspecting AVM or fistula, sometimes there is also intraspinal component within the spinal cord itself. It will be like edema or the edema will obscure the spinal cord itself, and you are not be sure if there is any tumor or not. So in this case, we can benefit from the dynamic sequences in the AVM.
Thank you.
Thank you.
Dr. Adil, I just wanted to ask one more question. This commonly we see the serings in the cord, like incidental finding. So, do you feel there is a need of contrast doing just to rule out any underlying enhancing nodule in the lesion? Like there is always a suspicion. So, do you recommend doing a contrast for this kind of incidental finding?
If there is, you mean intramedullary
Like we just see a serings commonly, like as an incidental finding without like any clinical relevance, but like just to do a contrast and rule out any associated enhancing nodule within the lesion. Although there is a theoretical risk, but do you feel like doing a contrast is worthwhile in this kind of finding?
Usually, if you see like serings, it's not always serings. Sometimes it's just a prominent central canal. But
Yeah.
usually, if we see like a central canal enlargement up to 3 or 4 millimeter, it's okay. But if it's more, we have to scan the whole spine, even without contrast, just to exclude any underlying tumor in the thoracic spine or at the conus medullaris. Contrast enhancement is not necessary always.
Okay, so you give more importance to size, like 3 to 4 millimeter of diameter. Anything more than that, you feel need to be seen entire cord and see for any other lesion.
Yes, of course, the prominent central canal, it's not, it's usually multi-segmental, but not more than 3 or 4 vertebral bodies. But if you see like extensive multi-segmental enlargement of the central canal here, you can't confidently say it's just a prominent central canal. It could be also serings, but usually up to 3-4 millimeter, it's acceptable if it's in short segmental.
Okay, okay. Thank you very much. It was a really nice presentation. You almost covered all the practical aspect. You had almost covered the practical. Yeah. Thank you very much.
Thank you too. Thank you for joining.
Any more question or explanation around the topic? Dr. Asamo can close the session.
Yes, we are good. I think it's fine.
Yeah.
Thank you very
Yeah.
much.
Thank you, Dr. Assam, for joining with us in this minutes. Thank you, Dr. Adil, for your presentation.
Thank you.
Thanks, Dr. Amul, for keeping up to organizing this CME hours. And thank you so much for our colleague to joining us in these minutes. Thank you for all. Thank you.
Thank you.
Thank you.
Thank you,
you.
Dr. Assam, Dr.
Thank you.
Amul, Dr. Yasser. Thank you very much.
Thank you.
Have a nice
Thank you,
day.
Dr. Adil.